to ask you a tough question, brilliant answer for each of you. Et Dr. Beaulieu, si vous me permettez une question en anglais, ça vous va? Okay. So I want to know, we've heard over and over again, primary care reform is a must. What's the one big obstacle? What's holding it up? We all agree it has to be done. What's the hold up in a minute or less?
Well, I think it's important that we see it as a system and not just see it as a primary care issue. And because a lot is in the collaboration also with what's going on elsewhere. Patients are moving around the continuum of care. So I think it's very important. And certainly, I mean, I just want to, we still invest a lot of importance in hospital-based care. And we should actually, I'm sure, try to be more, put money there. But I would say really collaboration and seeing it as a system with secondary care, regional authorities, community care is really what's the big barrier to me.
And are you confident? Are we going to see every patient with a medical home as you would like to see? Is that going to happen soon, before I die?
I think so, yes. They could be virtual homes, they could be networks. I think the movement is there. We have to continue in that direction and leave structures and really go with processes and commitment, what we're seeing, having a vision and then being practical, working out the problems and being practical.
Now, Chris, I want to ask you a question, and your presentation was so clear, I don't have a question on that. I want to ask you, wearing your CEO hat. So you go to a lot of these conferences, you hear about wonderful initiatives. Why don't we implement them all over the place? What's the problem for a CEO in taking the hip and knee thing and doing it in Halifax? And why don't we do all this stuff that we know we should be doing?
Well, you know, I think one of the issues is we always put the lens on of we need to have a local context, right? So that because it happens in Ontario, it may not be appropriate in Halifax, but yet we go all around the world or to IHI or to different places, and often we'll bring those things back to do. So, you know, I think for us, it's people often believe that if you don't, you know, if it's not coming from the ground up, if people in your own organization aren't the ones to initiate it and make it happen, then it's not going to work. I think we need to get over ourselves. There's tons of wonderful stuff happening. We're just starting to hear about that here, and we need to just pick it up and run with it.
Great. So Mark, the one question I had from your presentation, as I think a few people had it in the audience, is, well, it's easy for Saskatchewan to reduce wait times. They're rich. They've got all that potash. What about the money question? Is it about money or is it about something else?
You're right, we've been fortunate. We do have money to work through it right now, but I think the attitude we've taken is the money isn't always going to be there. We should assume that it won't be there in the future. And I think the changes that we're implementing right now, we've been fortunate enough to be able to do simultaneously to increasing volume, spending some of those potash dollars on more procedures. There's no, if we gave ourselves more time, if we weren't as ambitious, there's no reason that we couldn't have. In fact, ideally, we would be doing the lean improvement work. We would be doing implementation of pathways in multiple service lines before we ever got to using the brawn part of the brains and the brawn, and probably discover that we didn't need to add every last surgery that we'll add over this 4-year period if we sequence that differently. So I would just say to any jurisdiction, probably it would be better to do the quality improvement piece first and then determine how much of the volume you need to add in combination.
And one thing people, you mentioned it just at the end, but you're running out of time, but we often forget that you didn't only shorten wait times, you've actually reduced a lot of unnecessary surgery. That's a big part of it, right?
Absolutely, and I think, you know, between some of the themes, you know, different forms of assessment, shared decision making, involving clinicians in looking at variation, those are a few of the key things that we're doing to try and deal with demand. And I'd also say prevention, you know, by providing assessment and sealant to children living in northern health regions, we see that we can impact something like dental surgery almost immediately, or at least within a very short period of time, and that's another way of dealing with demand for surgery coming in the door.
And Deborah, one last one before we go to the responder. So in your clinic, what I see is people practicing to full scope of practice, specialization, teamwork. Again, 3 things that everybody says we should be doing. Why were you able to do it and it's not done, well, everywhere else at Sunnybrook and everywhere else in the country? What was the magical thing that got it done?
I think there were a number of contributing factors, but first of all, I think our biggest strength at the Holland Center is our team, because we have a unique culture and we had a long history with our orthopedic surgeons. And I think that it's really important that the team feels empowered and has a voice, and very much a part of our team was our patient voice. I think that too often, we think and we sit in our trenches and we think we know that we're doing a good job, and we aren't listening and talking to our patients. I mean, that was our experience 7 years ago. We got all of our team together, but very much part of our team was our patient voice. We were startled at what we were hearing, and there were consistent themes across the healthcare providers and patients. But I think another thing that we've learned in our 7-year experience, you can't sit back. We're constantly evolving our model, and we're constantly having to go back to the patient and saying, are we achieving what we think? And evaluation for us has been key. We've done a number of qualitative research studies now with our model, and where we thought like we had introduced better community resources, patients weren't actually being able to access our recommendations. So we've had to go back and look at how we did it. So our team has a huge voice, and that includes the patient. And I think that we're seeing, greater opportunities for interprofessional care, and it's been a theme today, but I know there's a respect for each of the different disciplines in our hospital.
Great, so the whole patient, not just their hips and knees. Great.
No.
So there is a patient responder who's supposed to have the mic, is that right? Yep, so fire away, and we'll give you the last word, that'd be appropriate.
Okay, my name is Anya Humphrey. I'm a family member of the Patient and Family Advisory Council to Cancer Care Ontario. And the question that I have prepared, in a sense, Ms. Kennedy answered already. But to me, patient and family-centered care involves both including patients and families in the design and delivery of projects. So I want to thank you all for the work you're doing, but I'd also like to ask the other 2 of you who have projects ongoing, how you may have involved patients and families in designing your projects, and also what feedback loops you've built into the system so that patients can let you know how well they're working.
So maybe Mark and Chris, if you want to talk about that quickly, how did the patients have their say up front?
Go ahead.
Well, I would say that this program was born because of the feedback from patients and families. In this particular, if talking about PATH, this particular program, because of their frustration of coming to our geriatricians and saying, nobody talks to me, nobody listens to me, I'm frustrated, I can't navigate through the system. So by listening to what the patients and families had to say, this was how this program was developed. So they were tremendously integral to that, and we have continual feedback through satisfaction surveys, et cetera, where people continue to feedback, and lots of letters come our way. More generally speaking, in our organization, one of our strategic directions is citizen and patient engagement. So we have a whole process around how patients are engaged, so we can truly deeply listen to what they're telling us. And it has fundamentally shifted for us where we're going and what we're trying to accomplish in our organization, because what patients and families continue to tell us is that we're not doing a good enough job, we don't listen to them, and what they really want from us is to keep them healthy. Be there for us when we're really sick, but help us to stay healthy. And so our everything we're doing is shifting. So we'll always be in that repair shop business, but we're really trying to shift to a focus on health. And we have patients and families engaged in every committee in our organization, in our business planning. We're very open and transparent. We could not do this work without them. It took us a long time to realize that, but we have. So thanks for the question.
I just wanted to say one last thing, too, that we heard from patients that they were happy to see other healthcare providers because they were so frustrated with not getting the information that it was even a loud voice that they were willing to see others. And so they wanted to see advanced physios. That was one of the recommendations when we actually talking to them, that I think that also helped support the team.
We've involved patient advisors both at the frontline service delivery level, with the surgical initiative being kind of a policy effort. We also brought patient advisors into that, which is a little different role for a patient advisor to be in. We have what we call a guiding coalition, approximately 80 people across our system, and I think we have 6, 8 patient advisors sitting on that group. Just one other example I'll give you is that in talking about lean, we have a team that comes together. It includes leaders in the system, frontline providers. There has to be a patient on every group, and the instruction that our system has been given is if the leader's not there, if the support's not there, you can go ahead, but if the patient's not there, the work doesn't continue. They're the only member of the team that stops the line in terms of that proceeding. One other comment I would make, and it's maybe just referencing back to Jeffrey Simpson, and I think from our perspective, the advantage of patient advisors isn't trying to get some kind of collective patient shared perspective, but it's the value of having a patient in the room, and there's nothing more successful in taking the ego of a physician, the bureaucraties of an administrator out of the conversation than having a patient sitting at the table. And I think that to me is where the value is, not necessarily expecting these groups to bring some common view to the table.
Et Dr. Beaulieu, un dernier petit mot.
Just to say, I just want to say that at our level at the college, we do have also a patient advisory committee to really guide us into the steering committee of the patient medical home. But also, I think there is really a need to develop a how to engage effectively with users and patients, how to do that at a level of, I'm thinking of the primary care settings and all that. And this is the kind of thing we really want to work on. That's on our, I would say, blueprint. So to develop that knowledge, so we need to do that with you as organizations.
So last word, I will remind you of the quote that imitation is the sincerest form of flattery. So the best thing you can do to thank our speakers is take their projects and steal them and implement them in where you work. So merci aux panélistes. Thank you.